not really a IT savvy, but I'll try to. Uh, I can I see? Okay. Don't know whether you can see me or not. Sekejap, Oh, never mind. I just do it. I just do it. Uh, can you see me? My face?
Yes.
You can.
Yes, we can.
You can see me, and you can see the PowerPoint.
Yep. Yes.
But I cannot see you. How do I see you? How do I? Sekejap. Sharing height. Let me see. Aduh. Now he's gone. Ah, okay. I see some of you now. It's good. It does make sense rather than just talking to this computer. Okay. So, Assalamualaikum warahmatullahi taala wabarakatuh.
Waalaikumsalam.
Okay, so start, guys. Now, where's the PowerPoint? Where's the screen? I need to go back to my PowerPoint. I'm still presenting here. The screen is small, kan? Dia tak slideshow. Is it?
Ah,
Hmm. Okay. All right. So we'll do pediatric upper airway obstruction. Um, so what I'm going to discuss in this topic is a bit about anatomy, so that it makes more sense. General clinical approach to management of kids with upper airway obstruction. And towards the end, we'll be discussing about management of some of the common uh, causes of upper airway obstruction. All the time, I'm doing this for pediatric patient, but some of it is applicable for adult patient as well. Yeah, it keeps on. So your faces disappear again. I must have pressed some other button. Uh, I want to see your faces at the same time I'm seeing the slides. How do I do that? Maybe I'll join both. It's okay lah. I cannot do it. It's okay. So, but you can see, right? And you can see and you can hear. Hello?
Yes, we can see and we can hear.
Time. That's not this time. Oh, I can hear. I can see. So, so we'll start with anatomy. We'll start with anatomy. So, to be able to appreciate how difficult it is to manage kids with upper airway obstruction, you must know about the differences in the anatomy between a pediatric upper airway and adult upper airway. So, if you can see the slides here, you can see that there are some differences in the anatomy in of the upper airway in pediatric and in an adult airway. Let's start with oral anatomy. In the oral cavity, um, because of the smaller size of the jaw and the relatively well-developed tongue, the airway in the very young, like the newborn up till a few months of age, is naturally obstructed in the oral cavity. In other words, they cannot breathe through their mouth because of this, what you call it, because of the crowded airway in the oral cavity. The crowded airway in the oral cavity, making it impossible for them to breathe through the mouth. So they are termed as obligate nasal breather. Um, they can only breathe through the nose at this age, maybe up until a few months of age. They are an obligate nasal breather. So any problem in the nose, like if they have a lot of secretion from rhinitis, kids are prone to have flu. So if they have a lot of secretion in the nose, both nose is filled with or blocked with the secretion, it can be a big deal for them because they cannot breathe through the mouth and both of the nose are blocked. Okay. And if you move on um, to the larynx, the position of the larynx is higher. The position of the larynx is higher in kids, in babies compared to adult. It's at C3 and C4 cervical vertebra in babies. And as we grow, the larynx descends to C4 to C6. Okay, what does it do to you, or how does this affect you when you are trying to secure the airway by means of intubation? You place the babies in a supine position. You want to look for the airway. You do a laryngoscope. You want to lift up the base of tongue. You want to see the epiglottis. You want to lift up the epiglottis and you want to see the vocal cord and you want to guide the ETT in. But when the position of the larynx is higher, it is almost always more difficult to see the position of the vocal cord and the airway because it will be higher and more anteriorly positioned. So it is not that easy compared to when you want to secure the airway in an adult patient. In an adult patient, the lower position of the larynx makes it easier to see the vocal cord and guide your ETT accordingly. The shape of the larynx in babies is also different than adult. If you can see the shape of the larynx here, this is the baby's larynx. The cricoid is a complete ring. Okay, thyroid cartilage is deficient posteriorly, so it is
a C-shaped ring. These thyroid and cricoid cartilage, they made up the, the, the cartilaginous framework of the larynx. In babies, when you are born, your cricoid is not well developed. So it's small. So when it is small and not well developed, it makes the shape of the larynx conical in shape, with a smaller size airway at the lower end. So a cone like this. So the narrowest part of kid's larynx is at the cricoid level. So where is cricoid? Cricoid is at the subglottic area. So you need to know that larynx is divided into three parts: supraglottic larynx, glottic itself, and subglottic. So cricoid is at the subglottic. So in babies, the narrowest part of baby's larynx is at the subglottis. Compared to adult larynx, the narrowest part of adult larynx is at the glottis itself. If you can imagine, glottis is a valve-like structure. Here, can you see my pointer? Hello?
No,
No,
doctor.
we
We
Can?
cannot
can't
see it.
hear.
Yeah. My pointer here, I'm
We,
pointing to the glottis,
we
which is a
cannot.
valve-like structure. So in adult larynx, glottis is the narrowest part of adult larynx, while in babies or pediatric larynx, it is the subglottic, because the shape of cricoid, of not the shape, the size of cricoid is smaller or less well developed. So it makes the shape of larynx in conical shape with the narrowest part of the pediatric larynx at the subglottis.
Sorry, doctor. We cannot see your pointer.
We cannot see. Okay. Can you see now? Here, roughly. Tak nampak.
No, doctor.
Can you see the picture of
The,
the PowerPoint? The PowerPoint you can see.
the PowerPoint you can
Yes.
see, but the
Okay.
the mouse or the pointer we cannot
You
see it.
can see.
It's
Okay,
not
it's
there.
okay. It's
It's okay.
okay. So, but you can just imagine that its larynx is the glottis is a valve-like structure. Valve, macam valve kan, macam injap. It opens and closes the glottis. So in adult patient, glottis is the narrowest part of their larynx, while in babies, below it, at the subglottic area, it's the narrowest part. Boleh? Hello?
Wait. Yes.
Okay. So how does this affect you when you want to secure the airway in uh, in the baby? Okay. Let's say you want to intubate. If you can see the vocal cord when you do laryngoscopy, you still not sure whether you can place the ETT correctly. Because why? Because it is not the narrowest part of the pediatric larynx. The glottis is not the narrowest part of the pediatric larynx. Bawah tu, it's below it. So in securing the airway in babies, you need to prepare a few smaller size ETT. Let's say you cannot push, you don't want to be pushing against a narrow airway because you may traumatize it. So you have to change to a smaller tube if you cannot pass the good size one. Okay, so in other words, all these anatomic features in babies makes it more difficult to handle and to manage. Another thing is, in babies, upper airway, they are soft and less mature compared to adult. Yeah, it's relatively immature. The cartilages is softer, tends to collapse readily, flaccid. So it's easier to get obstruction in baby's airway, and they tend to desaturate faster compared to adult. And the kids, the developing brain, they cannot sustain hypoxic injury longer than adult brain. So you have to be a bit urgent when managing a child with upper airway obstruction. Okay. Anybody with any question? Okay, let's skip that one. So in order for you to manage upper airway obstruction, you need to know what are the symptoms of upper airway obstruction in babies. The symptoms are these: stridor, stertor, and snoring. Have you heard of this? You've done your pediatric posting, right?
Yes.
So, yeah, so you've heard, hopefully, you heard of all the symptoms here. So these are the symptoms indicating there's some obstruction in the upper airway. So what are these? What are stridor? What are stertor? What are snoring? They are basically breathing sound. A sound you make when you are breathing through a partially obstructed upper airway. So where is the level of obstruction? In stridor, in stertor. In stridor, it is at the larynx. In stertor, it is above the larynx. So usually in the pharynx. And it can also be in the nasal cavity. What about snoring? Snoring is basically stertor. Okay? So snoring is an upper airway obstruction in the pharynx. It can be in the nose as well. Anything above the larynx. Stridor is at the larynx. So what about the quality of the noise? Stridor is often high pitch. High pitch, voluminous, while stertor is low pitch, coarse, hoarse noises. So snoring is basically stertoric breathing when you're sleeping. Okay, so we'll do snoring after this, but it's basically stertor, not stridor. Stridor is at the larynx. Stertor is above the larynx. That's all that you need to know. So let's talk about a few differential diagnoses. This will make your life easier if you know them. You know, management of stridor can be very stressful, especially to those inexperienced ones. You tend to forget things, you tend to mess up with things. So if you know the differential diagnosis, it'll make your management a bit more structured. Okay, so the easiest way to divide stridor is the causes of stridor is congenital and acquired. So what's congenital? Anything that you are born with. Do you need to have the symptom immediately at birth for congenital cause? Not really, actually. Anything up to 1 year can still be congenital cause, because some of the congenital causes are not readily observed or present at birth. Sometimes it is only aggravated or speeded up by an event like such as trauma or infection. What about acquired? Acquired is something that you are not born with, so you get it later in life. So what's the commonest cause of congenital stridor? What's the commonest cause of congenital stridor? It's basically laryngomalacia, until proven otherwise. Have you heard of laryngomalacia, guys?
No.
Are you still there?
Yes.
No.
If not heard of laryngomalacia,
We've read.
you've
But
read. So what's laryngomalacia?
it's
I can see some people here. It doesn't really make sense, as if I'm talking to myself. Yeah. First time I'm doing this. Basically, last batches I managed to see them person to person. This. So what's laryngomalacia, guys? Some 30% is in this. Aziz Saifullah, I can see you.
malformation of the larynx.
Yeah, okay. It's basically, um, yeah, it's some kind of malformation. It's not really, it can be normal, basically. It's immaturity in the framework of the larynx. So if you see the cartilaginous framework of the larynx, it is really immature. It's soft, tends to collapse readily. So that Malasic area, Malasic is soft, flaccid. Okay. So laryngotracheomalacia is the commonest congenital cause of stridor. It is basically a diagnosis of exclusion. You have to exclude this because it's so common. Over 90% of the whole causes of congenital cause is due to laryngotracheomalacia. Okay, so the rest of the causes are really rare. Second common causes may be vocal cord palsy, congenital vocal cord palsy, but it is still very rare. The rest are really even rarer, almost unheard of. Like for tertiary referral center, like HTA, for example, that caters for almost 1 million of population, you'll see this kind of um, laryngeal cysts, webs, cleft, like once every 2 years. That's how rare it is. But laryngotracheomalacia, it's very common. So you really have to exclude laryngotracheomalacia as the causes of congenital stridor, basically. What about quiet cause? A quiet cause can be febrile and non-febrile. Okay? Febrile cause, what's febrile cause? Infection. Okay? So stridor it is at the larynx. So some of the infection of the larynx is very common, like laryngitis, croup, for example. Have you heard of croup?
Yes.
Yeah, what's croup? What's the other name of croup?
Laryngotracheobronchitis.
Acute laryngotracheal bronchitis. Yes, that's good. So is it bacterial cause, viral cause? What's the
Viral.
cause?
Viral cause.
Viral cause. Okay, that's good. And laryngitis is often viral, so, but it can be bacterial cause. Another one is epiglottitis. Have you heard of epiglottitis?
Yes.
Yes.
Yeah, it's rare nowadays. What's the cause of epiglottitis?
Bacteria causes.
What bacteria? What is
Normal.
the cause of the normal or the usual causes of epiglottitis? Which bacteria?
Strep.
And
Pneumonia.
Streptococcus.
sorry?
Streptococcus.
Nowadays it is streptococcus and other gram-positive, but it used to be the commonest cause is due to Haemophilus influenza, HIP, Haemophilus influenza B. So because of the vaccination, you rarely see it now. Because of HIP vaccination, you rarely see acute epiglottitis. And nowadays, if you see epiglottitis, it's not normally due to HIP. unless you don't get vaccination. Some of the non-believers of vaccination, they still get. So it's often life-threatening. It's often fatal. Okay, the other acquired cause is non-febrile. Non-febrile cause, you should rule out trauma. Trauma leading to stenotic airway. The commonest traumatic cause is iatrogenic trauma. When you're talking about iatrogenic trauma, what comes in your mind?
Intubation.
Yeah, intubation trauma is the majority of the causes of acquired non-febrile stridor nowadays. Okay, so you really have to ask in the history of previous intubation, ventilation, if if the babies has been intubated, how many times, berapa lama ventilated, because the more in and out intubation, the more trauma to the airway and can lead to scarring and stenosis later. Another thing is you have to rule out foreign body. Foreign body in the airway is another common causes of acquired non-febrile stridor. In the age group of 6 months to 3 years, these are the ages when they started to mobilize around. They started to crawl, they started to walk, so it becomes orang kata apa, a bit more suspicious of things. They will pick up things, they swallow things. So the incidences of foreign body in the airway is higher at this age group. Okay, what about stertor? Again, you can divide it into congenital and acquired causes. But compared within congenital and acquired stertor, which one do you think is common? Commoner. Congenital ke acquired?
Quiet.
Yeah, it is by far commonly acquired cause. So let's talk about acquired cause of stertor. You can also divide it into febrile and non-febrile cause. When you are talking about febrile cause, you're talking about infections again. Some of the infections in the upper airway above the larynx is really common. Things like rhinitis, tonsillitis, adenoiditis, pharyngitis. This can lead to inflammation of the airway at that particular area. For example, rhinitis is inside the nose, the nasal mucosa is inflamed and narrower, and you get mucus secretion, mucus accumulation, leading to obstruction in the airway. So you can get stertoric noises. Again, stertor is coarse noises compared to stridor, high pitch. Stertor is low pitch. Can you hear? While stridor is something like that. Okay, so stertor can be due to a lot of secretion at the back of your throat, coupled with the narrowing and edematous airway. For example, you have a big tonsil, inflamed and enlarged tonsil that can obstruct the airway, right? Okay, so that's the febrile acquired cause. What about non-febrile cause? Again, you have to rule out foreign body, because foreign body in the airway is quite common too, especially in the nose. How does kids with the foreign body in the nose, they present to you? At the age group of 6 months to 3 years, normally they didn't tell you that they put something inside the nose. So what's the common presentation? How do you apa orang kata, how do you know, or what's the symptom normally they present to you?
Full breath and runny nose.
Runny nose,
And full breath sometimes. Full
And?
breath.
cold,
Full breath. Bukan. Maksudnya bau busuk daripada hidung.
yeah, foul smelly, unilateral nasal obstruction with foul smelly discharge. It's often unilateral. Kids ni, although they're smart, okay, once they put in one nose, they learn already and they don't want to put in the other nose lah. So it's often unilateral. But once they put something inside the nose, there's a blockage in the mucociliary clearance. That means the mucus gets obstructed. After one day, the mucus will accumulate surrounding the area of the foreign body. After 2 or 3 days, it'll start to get infection. It'll start to get foul smelly. So the normal presenting complaint is unilateral nasal obstruction with foul smelly discharge. So you really have to look for foreign body in the nose when you get that kind of case in that kind of age group. Can it happen in a bigger child? It can. Can it happen in an adult? Can it? Foreign
No.
body in the nose? It can happen, but it's usually a psychiatric causes. Can. So you really have to refer to the psychiatrist if it happen, especially if it's a recurrent thing. Okay. So that's a quiet cause of stertor. Congenital cause of stertor is really rare. Perhaps the commonest one is the top one, choanal atresia or choanal stenosis. Where is your posterior choana? Anybody? Where's your posterior choana? Kat mana? Tak pandai ya. I nampak Aziz Saifullah je gambar ni. Kesian kat dia. I nak tengok orang lain juga. Macam mana?
Boleh tekan hujung tu.
Tekan apa?
Dia ada participant kan, dia gambar.
Participant, but if I press, I can. Oh, sekejap. Yeah. Only your face appear. It's okay lah. So where is your posterior choana? Basically, it's at the back of the nose ke throat. Adel, are you around?
Yes.
Yes. Can you understand Malay? Where are you from, Adel?
Yaman.
Yemen. Yemeni brother. You've been here how long already in Malaysia?
Roughly 10 years.
10 years. Oh, so mesti pandai Melayu. Can you?
Boleh.
Sikit. Okay. So where is posterior choana? Have you heard?
Is it behind the nose near the mouth?
So it's at the back of the nose. It's basically the borderline between the nasal cavity and the nasopharynx. If you put a scope into the nose, it's an area after the nasal cavity proper. As you enter the nasopharynx, that's the area we call posterior choana. Okay, sometimes in the kids, that area fail to develop fully. So there is a remnant of either soft tissue or bony partition there. If it is totally blockage, so you get choanal atresia. That means there's no opening. But if it's small opening, then you call it choanal stenosis. So either way, it can lead to narrowing of the that area, leading to stertoric noises when you breathe, especially when you forcefully breathe through your nose. Okay, so that's the commonest congenital cause of stertor. The rest are not really common, so you can basically ignore. Okay, any question, guys, on the differential diagnosis? So you really have to appreciate this before you are managing a case of upper airway obstruction. You should have this differential diagnosis in your mind, at the back of your mind. Then your management will be systematic. Okay, so let's manage them. Let's say you have a kid, 1 year old, with stridor. You are the only doctor working in casualty at that day. So you have a 1 year old kid with stridor. So stridor is basically an emergency symptom. What are the emergency symptoms that you know? Anybody? So stridor indicates there's an obstruction in the airway. It's a dire emergency. Why? Because sometimes if you don't deal with it, the patient may die. And in ENT, there are only two dire emergency. One is airway emergency. Stridor is the symptoms of an airway emergency. What's the other one? What's the other ENT emergencies? Anybody? Normally we have this ENT emergencies covered in the seminar, but with this COVID, I don't think you'll have seminar. Aziz, what is other ENT emergencies? If you don't manage, the patient may die. Stridor is an ENT emergency. If you don't manage upper airway obstruction, the patient may die because they cannot breathe.
Sinus. Sinus patient or not? Or is it a sign?
Yeah.
Is it
Talking about the cause. Sinusitis, you mean? Sinusitis can kill you if you have complications.
Sinusis.
Sinusis is another airway emergency. It is the same.
This is same.
When you get stridorous child, it can lead to sinusis. Sinus is the sign. So basically, you're discussing about airway emergencies. Yes, that's an ENT emergencies. Airway emergencies, ENT emergencies, dire emergencies. If you don't deal with it, patient may die. I'm asking you another one.
Loss of appetite, poor oral intake. No.
No.
Hear loss.
Okay. Hearing loss is another ENT emergencies. There are many other ENT emergencies, but it's not dire emergencies. Hearing loss, you wake up in the morning and you cannot hear. It's an emergency. But will you die from it? Unlikely.
Unlikely.
So it is an ENT emergencies, but it's not considered as a dire emergencies. Faham tak?
Faham.
Airway, if you don't deal with it properly, you may die from it. What's the other one? What's the other cause that you need? Sorry?
Choking.
Choking is another airway emergency. It's the same. It's in the nose often.
Epistaxis.
Yes. If you get heavy nasal bleeding, you don't deal with it properly, you may die. Any bleeders anywhere, you have to stop the bleeding. Otherwise, you can bleed to death. And similarly, epistaxis, it can be very heavy, very massive bleeding, you know. So that's an ENT emergencies. You get epistaxis, especially sometimes from burst arteries, you know, or even at the veins at the back of the nose can be very big, and if you don't treat properly, you may die from it. Okay, so that's the two dire emergencies in ENT: airway emergencies and epistaxis. The rest, sudden hearing loss, acute vertigo, these are also considered ENT emergencies, but they are not dire emergencies. Basically, it's unlikely that you may die from it. It's considered as ENT emergencies because you need to treat them properly too. Failing to do so, you may have a permanent sequelae or permanent complication, like you may get permanent hearing loss, for example. Kan? So it is still an emergency, but it is not a dire emergency. Okay, so as of all emergencies, how do you manage emergencies? You really have to attend the patient immediately, resuscitate, assess, and resuscitate. So airway, breathing, circulation, assessment, and resuscitate accordingly. So that's the first step you should do. This is the same in all other emergencies. Chest pain, comatose patient, bleeding anywhere, you jumpa patient tepi jalan, convulsion. So these are all emergency symptoms. So you have to attend the patient, assess the airway, breathing, circulation, and resuscitate accordingly. So after you have resuscitated, I think you learn how to do resuscitation in anesthesiology, and in fact in PITS also, or in medical, or in surgery, or in ONG. So you've resuscitated, you want to find out the cause now. So you go back to the patient or to parents or whoever that brought the patient to the casualty. You want to find out the cause. So you take history. So in taking history, you want to rule out all these causes. So it is not that difficult. Basically, it's always straightforward. If you know your differential diagnosis, you can basically rule many of it by history taking alone. Okay, so you can ask whether this is a congenital or acquired. Like if it is congenital, it could have presented earlier. This is not the first time, or if this is the first time, maybe this is acquired. Okay, and if it is acquired, is it febrile or non-febrile? Simply by asking questions. I'm not teaching you how to take a history, but you can guide your history to rule out any of this, basically. Is that fair? Okay. So after history taking, you should have an idea already what your, or you should have a differential diagnosis in your mind. What's the likely cause you're dealing with now? So you go back to the kids and you do a proper examination. I know that you have already assessed the patient earlier in your ABC resuscitation, but now you want to see the progress you're making from your initial resuscitation, and you want to see whether you need to revise your resuscitation. You want to really look for the signs of improvement or signs of worsening, like listed here. Okay, so and you want to revise your resuscitation. For example, you may just give oxygen initially, but now you see that the child is getting worse with all the signs here, cyanosis, intercostal, and the saturation keeps on dropping. So maybe you want to secure the airway now by means of intubation. Okay, so that's your examination. So after you have done the examination, you want to think of doing some investigation. Why? You want to maybe confirm the cause, and at the same time, maybe this investigation is with the intention to treat at the same time. Okay, so in this situation, there are only two types of investigation that is beneficial. One is imaging, and the other one is scope. When we are talking about imaging in this acute situation, we are not talking about CT, MRI, PET scan, or any other orang kata fancy investigation. We are just talking about simple X-ray only, bedside X-ray, portable X-ray. Can you think of any cases that you may want to order for an X-ray?
Foreign body.
Yeah, foreign body maybe is the situation whereby it is beneficial to order for X-ray. Bear in mind, you don't order X-ray in all cases of stridor. Yeah. If you think this is congenital cause secondary to laryngomalacia, there's no point of you ordering for an X-ray. Okay. But if you think this is a foreign body, you can order for an X-ray. And sometimes it is confirmatory. If you see straight away a foreign body, because the foreign body may be radio opaque, like this, you can see the coin, or you can see any other opaque foreign body. Or if there is no foreign body, sometimes you can see other signs which may indicate strongly that the foreign body may be in one of the airway. Like here, you see hyperinflated or hyper expanded left side of the lung here. In a classical history suggestive of a foreign body, like a child previously healthy, presenting with sudden onset of stridor, you should rule out foreign body. And if you do X-ray in that kind of patient, you don't see an obesity, but you see these signs of hyper-inflated one side of the lung. This is an abnormal. You cannot do this purposely. Yeah, you cannot decide. Sometimes you want to use one lung saja. You want to rest on the right side. Yeah, I just want to breathe through the left side. Yeah, you cannot. So this is abnormal. So if you see these signs in the classical history or classical symptoms, you should rule out foreign body in this side of the airway. Okay, there's a high chances that there's a foreign body in the left airway, either in the bronchus or smaller airway. So given this X-ray picture with that history, you should go in, do a bronchoscopy, and really look for a foreign body in the left side of the airway, because there's high chances that there is a foreign body obstructing the airway there. Air can go in. Why air can go in? Because as you are breathing in, your airway is dilating, and there may be some space between the foreign body and the lumen of the airway to allow air to pass through it. But as you expire, it's a passive procedure. The airway collapses and may seal the foreign body, and the air gets trapped inside one side of the lung. Okay. Another investigation of a great help in this situation is scope. You are unfortunate enough not to be able to come and see our setting. in the clinic, but if you come later maybe and pay us a visit, you can see that all of our consultation room in our clinic is filled up with the scope. Scope has become a part and parcel of our essential tool. In other words, we depend so much on scope. So there are two types of scope. Flexible scope, the one at the bottom picture here, and the rigid scope. This is airway scope. So which one is for which? Flexible scope is good for diagnostic purpose. You can do it in anywhere. In the clinic, it's highly portable. You can bring it to the ward. You can do it in ICU, in OT. You can do it under sedation, or you can do it under nothing. So you can see the dynamic of the airway. You can detect airway collapse, the size of the airway, the patency of the airway, the collapsibility of the airway, how melisic the airway is. You can see from flexible scope. Rigid scope, the top picture here, is the one you can only use in the OT under general anesthesia. It is superior if you want to do procedures to treat the patient. It's inferior for diagnostic purpose because you can only do it in the OT, but rigid scope allows you to suspend. You boleh suspendkan dia, and then this is the picture, the right picture here, or the left picture, you nampak ada punya setting kan? You can suspend the rigid scope, so the surgeon's hands is free to do procedures. And at the same time, NS can connect their ventilator through here. There's a side port for ventilation. You cannot see my pointer kan? But look at the top picture here. There's a side port for ventilation in the rigid tube. And you can see that when you suspend the patient, you can connect the ventilator to the side port ventilation. So you can ventilate. NS is happy because they can ventilate the patient. We are happy because we can do surgery. We can, both of our hands are free to do the cutting, to do the lasers, to do the suction, to do any procedures. Okay, so this is the rigid endoscopy is meant for diagnostic, therapeutic at the same time. Okay, so it is less superior compared to flexible scope in terms of diagnosis, because once you put the rigid scope already, you are stenting the airway. You tak boleh nampak dah. You cannot see the dynamic of the airway. If airway collapse in any degree, you cannot appreciate it because you've already stenting the airway with the rigid tube. Yeah, any question? So we basically cover general management of airway obstruction. So start with ABC resuscitation. You take history, you want to find out the cause. You go back to the child, you re-examine and maybe revise your resuscitation or management, and then you want to consider doing investigation to confirm your diagnosis and at the same time sometimes to manage concurrently. Okay, guys, any question? This is the message that I want you to take from these slides. Okay, so let's go through some of the common causes and how do we manage them? Okay, are you up for it?
Yes.
You all dah makan kat rumah?
No. Ringan-ringan.
Ringan-ringan? Oh.
Ringan-ringan, Doktor.
So how do you enjoy your life at home? Everybody stay at home kan? Ke ada yang kat Mahalah? Tak ada
Ada
kan?
yang kepala Doktor.
Oh, ada yang kat Mahalah? Oh, ada eh?
Ada.
Ramai ke?
Tu Ibrahim Adel, Ishak,
Oh,
Afi.
ya. So, okay, some of you are in Mahalah lah. Okay, good. Now we'll do it and then we'll do it quickly and we'll have a break after. Do you guys have this PowerPoint slide?
Yes.
You guys have, right? I think
From previous batch.
I left it to previous students. I think it keeps on circulating around, so it's okay. You can always refer back to these slides. Okay, tracheostomy. I want to talk about tracheostomy because it is a life-saving procedure in ENT. You must know how to do tracheostomy to become an ENT surgeon, because this is our emergency life-saving procedures. So in ENT, you don't need to know how we do surgical procedures, but you need to know indications of some of the common procedures we do. Things like tracheostomy, things like maybe tonsillectomy, adenidectomy, myringotomy and grommet, apa lagi? Laryngoplasty, maybe. That's a common surgery we do, and you should know what's the indication of doing it. Okay, we won't ask you how to do it, but we can ask you the indications for doing it. Okay, so tracheostomy, you see here, you should be able to recognize that it is a tracheostomy lah, in the first place. Okay, so the causes is quite obvious. The indications here, you see a very big mass from the mouth in this congenital mass in this newborn baby. Immediately had airway obstruction, so the pediatrician and anesthetist cannot intubate because there's no way they can put the laryngoscope through the mouth and see the airway. So we had to do emergency trachea. This is the unfortunate baby. After tracheostomy and removal of the mass. And this baby also had a congenital malformation. The upper airway is not developed. There's flat chin here. There's no jaw, basically. Mouth opening is very limited. You cannot put the smallest size laryngoscope through this. So let alone to intubate. So we had to do tracheostomy immediately at birth. So some of the indications for tracheostomy is very clear there. Okay, laryngomalacia. What is laryngomalacia? We talked about laryngomalacia earlier, and I'm sure you had learned about laryngomalacia in pediatric before. So it is floppy or immature larynx. It's 90% of the cause of congenital stridor. So it's basically a diagnosis of exclusion. If you have congenital stridor, you should think of laryngomalacia as the first diagnosis. The good thing about laryngomalacia is it's 90% self-limiting. In other words, you don't need to do anything. It will improve with time. Yeah. If you scope the baby, you can confirm the diagnosis. Forget about type 1, 2, 3. What you should see is upper airway collapse upon inspiration. Okay, so because of the obstruction is at the supraglottic larynx, you see the airway collapse in some degree. When the child is breathing in, you see the supraglottic airway collapse. You can see either epiglottis is being sucked into collapsed epiglottis, collapsed airy epiglottic fold, thickened airy epiglottic fold, flaccid supraglottic structure, but you should be able to see airway collapse in any degree upon inspiration. So that's diagnostic of laryngomalacia. So what's the treatment? It's conservative in 90% of the case because it improves with time. So what you need to do is to counsel the parents for proper feeding. Proper feeding, you feed them normally sitting up. Try to avoid feeding them while they are in a supine position. Okay. Sometimes you should feed with the elongated nipple. Sometimes ada dijual. Not the usual nipple, but it's slightly elongated to bypass the airway straight to the esophagus. Or you can use a syringe to feed the baby. With the conservative measure, if still the child is severe enough, then you should do this surgery called airy epiglottopexy. It's basically cutting off and opening up the supraglottic structure. You don't need to know how we do it, but basically we want to reduce the pulling effect of the epiglottis by this thickened airy epiglottic fold. This is airy epiglottic fold. The top left picture here is the laser probe cutting the airy epiglottic fold. So after we cut it, this operation is called airy epiglottopexy or plasty. So it leads to a fibrotic scar, and at the same time you kind of release it from tightening up or increase pulling effect on the epiglottis. So that's the common operation for laryngomalacia. This slide tells you when to operate. When you have all these severe symptoms and it's not resolved with conservative measure, then you do that surgery. Sometimes you need to do tracheostomy. Tracheostomy is 100% effective because you have bypassed the narrowed airway above. Okay, so you have already bypassed it down. You put the trachea in the trachea, so you have bypassed the narrowed ataupun the obstructed upper airway. Okay, subglottic stenosis is commonly due to iatrogenic trauma. In our setting and in everywhere also, is due to traumatic intubation. Intubation trauma is the commonest cause of subglottic stenosis. How do they normally present? They don't present immediately after a history of intubation. Often the scar tissue develops slowly over months, sometimes 2-3 months, baru dia show symptoms. Okay? So in the history, you should take about history of intubation. So when you scope, you see this is the subglottic area. You nampak ada narrowing here, scar tissue formation leading to narrow airway. You can grade the severity. Grade 4 being total occlusion. Grade 3 is more than 70% occlusion. So grade 3 and grade 4 is the severe one. So how do we manage? Briefly, I'll show you some of the surgery technique. You don't need to know. You don't need to know how we do surgery. Yeah? This is laser resection of the stenotic airway. This is balloon dilatation. You can dilate it with balloon. This is open surgery. For grade 3 and 4, often you need to do open surgery because balloon dilatation and laser resection often does not work as well. So you need to open the airway, cut the stenotic segment, and then suture back the proximal and distal airway. This is another technique, different technique, whereby you take a graft from the costal cartilage, rib cartilage, you open up the airway, if you can see my finger here, you open up the airway, you remove the stenotic segment, and you stand the airway. This is called airway augmentation procedure. You nampak tak dekat the lower picture, right? Bottom picture, the graph is in situ. Okay. Tonsillectomy, adenoidectomy, tonsillitis, adenoiditis, pharyngitis is common childhood infection. We treat it with antibiotic. You need to know the indication for surgery, for tonsillectomy and adenoidectomy. Croup M epiglottitis, you also manage medically. There's a difference between croup and epiglottitis. One is caused by viral, one is by bacteria. So the management is slightly different. Foreign body in the airway, you do rigid bronchoscopy and you remove them. Vocal cord palsy, if you have a congenital abductor, bilateral abductor palsy, the vocal cord fail to abduct. So it is in an adducted position. That means it's at the midline. So a very narrow airway there. So after a while, we leave it for 6 months normally. Sometimes it spontaneously recover, but after 6 months, if it does not recover, you can do laser chordectomy, whereby you use a laser to open up a posterior 1/3 of either one side or both sides of the airway. You get a degree of hoarseness with this procedure, but it is essential that you taper down how much you remove and how big the airway size is. Kalau you remove too much, the airway becomes better because they can breathe better in the bigger airway, but the voice will be more muffled. Okay, web. Congenital web, the surgery done to it is that you do a laser surgery, you just cut the web. And similarly, hemangioma, nowadays we treat first with beta blocker. Propranolol is shown to shrink some of this tumor. So this has been our first line of management first. Failing this, then we can do surgery, but it is quite bloody because hemangioma is a vascular tumor. So you need to sometimes embolize it. We ask the help of our interventional radiologists to secure the blood supply to this tumor first. They can inject some fat or some sclerosing agent to the vascular supply to this tumor before we do surgery to minimize blood loss. Okay, cyst. It can occur anywhere in the upper airway. This is vallicular cyst. Where is your vallicular? Have you heard?
Yes, we have heard vallicular.
Where?
The between esophagus and also the larynx. There's
between the epiglottis and the skull, the tongue base. Okay.
Yeah.
So base of tongue and the epiglottis, that's your vallicular area. So you can imagine this cystic mass is at the vallicular area. So if you have a big mass there, it can push the epiglottis into closing the airway. So it can be, if it is an acutely enlarging cyst, so it can push the airway down. Okay? So, or close the airway down. So what we do is we need to remove the cyst. The procedure is not that difficult. You just open up the cyst, drain out the cystic content and trim the edges of the cyst. Similar also, if you have glottic cyst, you just need to open up the cyst and drain. And subglottic cyst also the same. Recurrent respiratory papillomatosis is due to HPV virus. HPV is difficult to eradicate. So management of this condition is also quite difficult. Sometimes you have to do multiple surgery, multiple debulking surgery, followed by antiviral medications, anti-tumor medications, and you have to do it repeatedly until the viral load is cleared and the polypoid warts is cleared. Okay, a word about choanal atresia or choanal stenosis. We talk about choanal atresia being the commonest congenital cause of stir talk just now. If you have bilateral choanal atresia, you are born with it. Immediately at birth, you'll find it difficult to breathe. Why? Because the nose, there's no space for breathing. And naturally, we talk about anatomy in the oral cavity in the newborn. Can remember, whereby your tongue occupies the whole part of your oral cavity. So you are practically no space to breathe through the mouth as well. So when you have both nose and mouth blocked, so you will be shortness of breath immediately at birth. So what you need to do is maybe you need to intubate the baby and then refer to us, and we'll create the airway by means of surgery. We need to drill out the airway in the nose. We often do it in a month's time. We prep up the baby, optimize the baby weight and everything for surgery, and we do surgery. Often we do it with power instrumentation. We pass the drill, we drill out the opening. So simply said, so you drill out the opening at the back of the nose. Okay, guys, that's it for this topic. Now it's 10 o'clock. Any questions you have? I think we need a 30 minutes break. Okay?
Okay, Doctor. Okay, Doctor.
Okay, boleh eh?
Boleh,
Adil,
boleh.
where are you? Are you in Mahala? Hello?
Ibrahim.
Ibrahim,
Yes,
you call him?
yeah, we call him Ibrahim.
Ibrahim. Ibrahim, are you in Mahala?
Yes, doctor.
Are there many students in Mahala?
Yes, from different kuliah, yeah.
Yeah, from different kuliah. There are still many of you.
Yes. Kuliah of
Oh,
nursing, kuliah of health science.
Oh, are they all from overseas, or some of them are local students as well?
Majority are local.
Majority are local. Okay, that's good. So you're not alone, lah. Okay, so you go have breakfast for half an hour. Maybe we'll see again. Now it's 10 past 10.